I'm the founding co-director of the Institute for Health Equity Research, and I'm a professor of emergency medicine and of population health science and policy, as well as a professor of artificial intelligence and human health at the Icahn School of Medicine at Mount Sinai. That's a big question. Race is what we call a social construct. So where I start with this is the fact that there are decades of evidence that document startling differences in health and health outcomes amongst people from various racial categories. So we refer to these as health disparities. There are differences in life expectancy, in burden of disease, in all of the health outcomes that we measure. Black people and Latinx people, as well as American Indians and Alaskan Natives, all fare much worse, have poorer levels of health and much worse health outcomes across the board. So there's this tremendous body of evidence that racial categories are associated with really big differences in health. But race is not a biological category. Race is a socially constructed category that basically divides people based on how we look. And in this country, people who have darker skin and certain kinds of features are seen by certain segments of the population as being not equal, not the same as people who are white. And there's a long history of this kind of racism in America. So racism is this system of assigning value and allocating resources, which has disadvantaged certain population groups for centuries. It's important to understand, though, that race is not a biological category. And if you try to understand the underlying causes of these differences in health outcomes, much of it leads back to the racism that's embedded in American society that has really given unequal access to all of the resources that we need to sustain health. This is not just healthcare, access to high quality healthcare, but also access to nutritious food, safe places to live, an environment that isn't polluted or that has dangerous toxins in the substandard housing. And so the relationship between race and racism is complex. And it's only in the last few years, I would say, that we've really been able to talk very openly about how racism has had an impact on the health of certain racial groups in this country. Scholars like myself have been talking about this for a long time, but now there's a public dialogue really recognizing how racism impacts in a very adverse way certain racial groups. So our Institute for Health Equity Research is a relatively new institute that includes investigators who've been working on health disparities and health inequities for a long time. It's founded by Dr. Carol Horowitz and myself, and the work continues in a number of areas. One of my specific interests is really looking at health care disparities. And so these are differences in the health care that is provided to various groups. You know, in this country, we measure the quality of health care all the time. It's required by regulatory bodies and by payers. And so all doctors and hospitals and medical practices are constantly looking at these metrics to assess the quality of the care they deliver. And what we found is if you separate those metrics based on the race and ethnicity of the patients, that people are not necessarily receiving the same quality of care. They often don't have access to the same healthcare services, and they may not be receiving the same quality of healthcare. So this is something that our institute has been studying very deliberately, and we've already been able to identify several specific practices that have been disadvantaging Black and Latinx patients in our healthcare system, and we've been able to correct those. So this includes, for example, there are tools that doctors use to calculate the risk of certain diseases or certain outcomes, and doctors use these rules to decide perhaps who gets put on a certain medication or who's eligible for a certain kind of treatment or intervention. And when we started looking carefully at some of these tools, they actually had a racial bias embedded into the calculations. And this has been a conversation nationally amongst academic health centers, but Mount Sinai has moved, I think, very proactively to review all of the clinical algorithms that are in use across our system, and to look at the evidence basis to see whether or not race is appropriately included, or if it's included in a way that actually disadvantages Blacks or other groups of patients. And we've actually eliminated the use of tools that we feel are flawed, that actually were disadvantaging patients. As I'm sure is obvious to your viewers, I am a Black woman, and I think one of the reasons that I became a physician was to be able to make sure that my community got access to high quality healthcare. And when I became trained as a researcher, I was very interested in these issues of health disparities and healthcare disparities, trying to understand the underlying causes, but more importantly, trying to devise solutions and interventions that would eliminate these very startling differences in health for certain populations. And I'm very excited now with our Institute for Health Equity Research to have this collection of very talented scientists from different disciplines all thinking together about how do we address these longstanding inequities that really have disadvantaged people. And it really makes a difference in terms of how long people live, what kinds of illnesses they have, and really their quality of life. And so I'm quite passionate about doing this kind of research, and really excited with some of the projects that we've been able to launch now at the Institute, such as looking at these race-based clinical algorithms and eliminating them from our health system. Well, again, the causes of disparities are complex. It's not just one thing, it's lots of different things. And so the solutions will have to address all of those different underlying causes. This means that we need to understand what the, sometimes, for example, there are genetic predispositions to certain kinds of things, and the risks of those may be unevenly distributed amongst racial and ethnic groups. Sometimes there are underlying chronic diseases which put people at risk for certain complications, and we need to look at how those conditions developed, why those conditions are worse in certain populations, and how do we actually eliminate those differences in health. Some of this is access to healthcare. Some of it is access to healthy foods, to safe places to walk, to have places where you can have safe physical activity. Some of it is related to differences in the places where people live, where perhaps the housing stock has toxins and contaminants that help to make them sick. Some people live in places where the air pollution is worse, and that actually can make pulmonary diseases or sometimes even other systems, other organ system diseases worse. And so the more we study the underlying causes of disparities, the more we learn about how complicated this is and how we're really going to have to address this on multiple fronts. And that's why it's so important that all kinds of researchers, whatever your clinical discipline, whether you study heart disease or lung disease or kidney disease or diabetes, that all of the research on all of these conditions really need to be done with what we call a health equity lens to try to help us understand why there are these differences and what we can do about them. So the COVID-19 pandemic has been devastating across the board, but it has really magnified the underlying differences in health that existed for Black communities, for Latinx communities, for American Indian and Native Alaskan communities. And so what we have seen since the beginning of the pandemic is that, first of all, individuals from these racial and ethnic groups are more likely to be infected with COVID. And this is because of the roles that they play in our society. We know that people who were not able to work remotely, people who actually have to leave their homes and get on public transportation and go to jobs where they interact with members of the public, whether these are people who work in hospitals or people who work in grocery stores, that these jobs put people at increased risk of contracting COVID. And Black and Latinx individuals are disproportionately the ones who have these kinds of essential jobs in our society because they tend to be lower paying and have fewer educational requirements. And so this has put people at greater risk of being infected by COVID. But the underlying differences in health, the fact that they're more likely to have high blood pressure or heart disease or diabetes or kidney disease, also places them at greater risk of dying when they do contract COVID. And so this disproportionate impact has been seen both in terms of who gets COVID and what happens once you have COVID. How likely are you to be hospitalized and how likely are you to die? And the disproportionate impact was seen immediately at the beginning of the pandemic and really has been sustained throughout all of the waves. This fourth wave, so-called fourth wave with Omicron, has actually seen a slight narrowing of the disparities. And that's because Omicron is just so easy to catch. And so compared to the other waves of COVID, Omicron is more likely to infect even people who are not out in the public, people who have tried to stay home, people who work remotely. Even those people have become infected because this is so infectious, this variant, it's so easy to catch. But the disparities persist and the evidence really continues to mount. It's quite grim. A recent analysis looked at the excess deaths due to COVID. Now, of course, the excess deaths due to COVID cut across all racial and ethnic groups, all ages and genders. But when you analyze those excess deaths, so these are deaths that are attributable to COVID, either directly because people died of COVID or indirectly because people did not die from COVID, but they died because of COVID from other causes. that again, there are disproportionate impacts on Blacks, with the excess deaths being very substantially greater in Blacks and Latinx populations. So this is this is something that is going to impact Black and Latinx communities going forward. All of the loss of life, the grief over the people who've been lost, the economic instability that's been created by the pandemic. Businesses have closed, jobs have been lost, people have been evicted from their homes. And so all of these things, again, fall disproportionately on those populations that were already most disadvantaged and that were really already impacted by these racial and ethnic health disparities that have been longstanding. So they preceded COVID, but now COVID has really amplified the impact on these communities. Well, one of the first things we did very early in the pandemic is that we reached out to community partners whom investigators at the Institute have been working with for decades. And so these are community organizations that provide services or are advocacy groups. We reached out to them and said, we'd like to talk about COVID. We'd like to know what you think we should be studying. And the response was overwhelming. Literally over 100 community organizations answered our initial question, saying, yes, we want to talk about COVID and what this is doing to our communities. And when we got them together, what was most striking is that what they were most worried about was the impact that COVID was having on the mental and emotional well-being of our communities. That they were really worried about how the fear of COVID, the actual having COVID illness, the economic devastation that COVID was wreaking on these communities, the concurrent epidemic of police violence, watching a Black man be murdered by a white police officer on the evening news, that all of these things were coming together to create a tremendous stress and anxiety and depression in our communities. And we were a little bit surprised that that's what they really identified, but it was across the board. And so we put together a community survey with the help of these community partners, and we've been distributing this throughout New York City in 11 languages since the beginning of the pandemic. And the responses absolutely confirmed what the community partners have told us. People are anxious, they're depressed, they're stressed. They're actually undergoing a syndrome where they have PTSD-like symptoms from the impact that COVID is having on their lives. And so we have started thinking about what are the strategies that we can employ in our communities to help address the mental health and emotional well-being of our community members. So that's one line of research that we're very excited about. And the other really is looking at how we can, again, this is COVID-related work, how we can work with our community partners to improve vaccination rates and testing rates to really try to optimize all of the things that our communities can do to protect themselves from the impact of COVID. And that's work we've recently been funded by NIH to do with other academic partners across the city. And then, as I mentioned, on the healthcare delivery side, doing a systematic examination of the quality of care that are received by patients who are Black or Latinx, to really see where there are differences in the access to healthcare services and in the quality of the healthcare actually provided, and then deploying interventions to eliminate those differences so that everybody gets the healthcare that they need to really try to optimize their health outcomes. As is often said, Black history is American history. And I think the value of having a Black History Month is to really call attention to the many ways in which Black people have contributed to this country in very positive ways, but also to lift up our story about the struggles that we have had, the impact that racism and discrimination have had on Black people throughout America's history, and to really recognize where we are at this moment in time and what still needs to be done. As the saying goes, much has changed and much has not. And I think that the last 2 years have really shown a spotlight on the ways in which Black people have been systematically excluded from resources, from educational opportunities, from economic opportunities, from housing choices, and that if we really want that to change, then there has to be a very intentional look at all of our systems and processes and organizations to understand the ways in which structural racism are embedded in our society and to dismantle those inequitable structures. And I think there are many large institutions and businesses and corporations that have started to do this. I know that I saw many statements on equity and inclusion that have come out over the last year and a half. And now we need for those statements, for those plans, for those aspirationally articulated ideals to actually be put into practice. So this is the hard work of changing the way that we do business in this country in ways that give everybody an equal opportunity to live a healthy life.